Our next speaker for session 1 is Dr. Roos Pot-Kolder. Roos is a postdoctoral fellow at the University of Melbourne and Orygen in virtual reality for youth mental health. She's a pioneer in Dutch virtual reality and has been delivering virtual reality therapies and research since 2012. She's an experienced VR therapist for social phobia, psychotic disorders, and agoraphobia. I might have to go work with you a bit on the social phobia. Roos will be speaking to us about incorporating equity considerations and co-design of youth mental health solutions. Thank you, Roos.
Thank you. Thank you for having me. I will start sharing my screen. It should be loading. All right, thank you for having me in the introduction. I'm calling in today from the lands of the Wurundjeri people of the Kulin Nation, traditional owners of the land who have cared for it for thousands of years. And I would like to offer my respects to elders past, present, and emerging. Most of the time I present on virtuality, I do so on how amazing it is. And there's a little bit of time for that and all the possibilities it offers. But there's also a bit of a darker side, which will be more of the focus of the presentation today. And that is, it extends both to software and hardware. So first, what are we talking about when I talk about virtuality? I'm talking about immersive virtual reality. So the computer makes an image and you have two sort of little computer screens in your virtual reality glasses, stereoscopic. There's a tracker in the virtual reality goggles and they track whatever you're doing and feedback this to the computer, which updates the image. This all goes so fast, or should go so fast, that it feels like it's responding immediately. And what it does, even though you can see it's not real and you know it's not real, it creates a sense of presence in the interactive 3D environment. And we use that presence, that experience, to provide virtual reality therapies. Because even though it is not real, your body responds as if it's real, which means the learning effects is also real. A bit more on that later. So why would we even want to use virtuality as psychology researchers and therapists? Well, we want to treat and research the problems that people experience in everyday life. And everyday life does not look like the research and therapy settings. This is actually quite a nice therapy setting. What it does look like is more something like this. And we are very social beings, and we have a social context in which our psychological problems emerge and take place and interact with. So what virtuality would offer us is that it forms a bridge between the between the therapy room, in this case, and the actual real world. And how we do that is by recreating environments, social environments in virtual reality. So even now, though, as a therapist, I have a client in my therapy room, I can still bring in the therapy room a bus or an airplane or whatever anxiety I am treating or dealing with, or the client wants to practice. There are many advantages to this, but I'll sort of skip over those today. If you want to know more about them, feel free to contact me afterwards as well. It's just that it's much more easier if you're scared of something to start doing it virtually. And we do see results generalized to real life. There's been a lot of research already on this, luckily, be it in kind of different ways. The first headsets were being built in the 60s, much more uncomfortable. But even when I started about 10 to 12 years ago, we would have headsets like the one on the right. They would be hand-built around 30,000 Australian dollar. That's excluding inflation. But the advantage is that we do have knowledge already. About 25 years of VR research in psychology, mostly on cognitive behavioral therapy, on relaxation and mindfulness techniques, and on skill training like social skills. Software has come a long way as well. At first, it was more like things like fear of heights could be built. And now that the computers got more powerful, we could actually recreate the social environments. As you see below, this was the one I used for my study in 2013. They can get more and more complex. In short, there have been quite a lot of meta-analysis. VR works really well in anxiety disorders, all sorts of different disorders, but there's also hallucinations and paranoia. And there's emerging evidence on other psychological challenges as well. And I think for us, it's mostly finding out, what does virtuality add? Like you can see on the picture, does it add something of value to our therapies and to our, and in which way can we use that? That's a journey we are on as a field. But what we see is that especially young people, they call them the digital natives, the people born after 1990, they pick this up very well and very quickly. And it's easy to work with, and often they prefer it. But there are problems. There are definitely a sort of a darker side of these virtual representations and virtual environments. Because when I started building my software for my first intervention, this was an intervention for paranoid anxiety in the Netherlands, then we found out that we have only Caucasian, slim, young virtual people available in Western clothes, while most of our inclusions centers are in the big cities. We have large populations of people with a North African background, like from Morocco or Turkey, and none of these were represented, apart from even all the other challenges like age and body size, body shapes. But that was a problem. There was no diversity. We had to manually build them. We asked people, friends and family members of the software company as well, to provide pictures if they would want to, and they could digitalize them, and we would have more diversity in nationality in our software. But we had to hand build them. Same for cultural and religious expressions. There weren't any, so we had to build them as well. But we quickly ran out of money. So we barely made a dent in cultural diversity. We just chose, the biggest group we had in the big cities where we worked. But even body type diversity, age diversity, we didn't even get to that. So once you talk about diversity, or I think it was mentioned by one of the earlier speakers, it's not as much sometimes about inclusion as who you exclude. And we virtually exclude a lot of people at this point. The other side is the accessibility of software and hardware for people to actually use, to actually profit from these therapies. By the ones at first, they were built by the uni, just like the hand-built headsets. And after the project, they would not be updated, they would not be kept up, they would end up in the closets, not used at all. For our project, therefore, from PhD project, we decided to work with a commercial company in the hopes they would keep it up and keep it available, which that part did work, except they were a commercial company. We signed off all the rights, and they now charge 15,000 Australian dollars for one license for 1 year. So that's a problem, because there is still only a small group at the moment in the Netherlands who can access it. And it's usually through other studies and universities who have some room to put these kind of things in their budgets. And accessibility is a big, big problem. So now I'm moving to Australia about a year ago to the new virtuality lab. And we want to make virtual social environments for young Australians. In the mental health journey, we often see that the problems they experience already starts in adolescence. And this has a big impact on their social development, because this is a big social development phase in life where you learn about your own identity and your social identity, and you create friendship and learn about intimate relationships. And that all of that gets damaged, can be damaged by mental health issues. So we see a large decline in social functioning in a big group of people. And together with my colleague, Dean Colivas, who's a lived experience researcher, we started talking to youth advisors, because we didn't build anything yet. We first wanted to talk to them. And so they told us what they would need and what they would want from us. And they mentioned, of course, very much social environments that they are using, such as coffee cafes or university and school, public transport, But he also had a clear voice, a clear opinion on that there should be diversity and accessibility of anything that we develop. Great. So we have a clear to-do list from our youth advisors on what to work on. They helped us through several workshops and live one-on-one interviews, because these were people with lived experience as well. So we wanted to create a sort of a safe environment for them to share this information. And we continued these kind of workshops online, even though we are allowed to do them in person by now, because we learned during the pandemic that it actually offers a lot more voices to the table. We have a lot of people from outside of the big cities joining us now in these kind of virtual workshops. And especially as we work with social anxieties and social paranoid anxieties, we now have people joining us, for example, without a camera, or if they're having a bad day, even with just on the chat. But that's a low level way in which we can listen to their voices and their opinions and include them. We will continue to be doing that. They made a lot of mood boards. We had a lot of conversations on what they need. And then we started building. 10 years later, this is the software our developers use. Character Creator 4 is quite a new software. And well, what did we find out? The default is still a Caucasian male and a Caucasian female. Anything that deviates from that needs to be built or bought, or so the quality you see is quite improved, but some things are still a big problem. I'm just going to show what a therapy looks like for context. This is a small demo we made just for reference how something like this would look like, therapy.
Hi, good morning. Welcome to your cafe.
Hello, how are you?
Good. What can I get for you today? Want to have a look at our menu? It's on the right.
Oh, all right. All right. Americano espresso.
See anything you like?
Do you have something without coffee?
I can get you a hot chocolate or a cup of tea if you like.
Oh yeah, hot chocolate sounds wonderful.
That'll be $18, please.
Ooh, all right.
Ecuadorian chocolate.
Oh, excellent. Can I pay with card?
Yes, please.
Mhm.
Oh, I'm sorry, mister. Your card's declined. Want to try again? Card approved. Yeah, awesome. I got you your hot chocolates on the left. You can grab it if you like. Enjoy. Have a good day.
You too. Thank you very much.
All right. So as you can see, this was a very Caucasian female supermodel. That is the standard at the moment, and everything else we will need to build. So we looked into what would be needed to create this diversity and representation in virtual environments, virtual social environments. And some things have improved in the last 10 years. That's good. There is much more age diversity available, or at least semi-available. There are now within the program sliders to add wrinkles. And if you want a full age package, so more detailed avatar age details, then you can at least buy it. Same with body types. At least there is a slider now available within the program, which can create different body types apart from the supermodel one. And that's a small improvement. But, and this is a big problem, skin color appeared to be still a big problem in it being not available. So there are the Caucasian skin colors you just saw in the video as well. But if you want other natural skin colors, you don't have sliders for that available. And at the moment, it's quite a new software program. Also, no packages we can buy. We do have, frustratingly, I can make people green. We have a slider for green within the program, but I cannot give them a beautiful dark skin color. Very frustrating. Same goes for cultural diverse facial characteristics or hair types. There are 3 hair types available in the default setting, all Caucasian. What does it mean that 10 years later, we will still be collecting pictures, probably, from friends and family, and digitalize them again in the virtual environments to make sure we create inclusive and diverse environments? It is quite new software. We do hope that as you usually see more packages coming available by third parties during once one software is a bit longer on the market, but it's good to be aware that the default is still white Caucasian. Same is diversity in clothing, and this was actually something that our youth advisors really felt strong about, that the big part of their peer identity and subculture identity as young people often is expressed in clothing and looks, whether it be their cultural backgrounds or whether it be other colorful ways to show and express their identity. None of this is available. We will all have to build them. Same goes for ability and gender diversity. It's a bit of a frustrating, because you can feel like I keep continuing to have the same message that it's not available, but unfortunately that is the dark side of VR at the moment. We did hope that we would at least have a virtual wheelchair, for example, available, that we could program a person within the wheelchair, but at the moment there's not. So we will need a lot of creativity and resources to work around that. Another big thing that came up in our young people is they definitely do not see gender as binary, which is still how the programs work. And if many of them, be it some of the young people really express, like I and my friends, we identify as non-binary, and we want to be able to see that as well and have that represented in the social environments, and not erase us. And it feels like we really need to listen to that. We will have to find and build ways around that. So this part, second part, is more about the accessibility. If you look at the hardware and software, because we have this great digital healthcare gap in accessibility. And if you look about 10 years ago, this is what was available at universities when I started working with it. It was a hand-built virtual reality headset, which was unaffordable. There you would need about 4 computers even to have a basic training program. This would be run by a PhD student from a technical university. And if they were having exams, then you would have a problem, because your client would just have to wait for a week. It did get better, that part. The gaming industry really took up the virtuality hardware. So it's still quite expensive, but compared to 10 years ago, you see a significant drop in prices. It's around 700 Australian dollars, I think, for Oculus Quest at the moment. And you need one, still very good, but you need one laptop for this, making it also mobile intervention and being able to go to different locations and different, for example, people are too scared to leave their house in the social anxiety spectrum. But again, a big but. You can see the hand tracking here. So that's a big development, a recent development that we love, because it makes it so much more easy to use, even for people who are not used to technology. And so instead of the clunky controllers, you have a very intuitive hand tracking, as you can see in the video as well. You just use your hand to grab, and then in the virtual environment, it grabs the coffee cup, for example, or you poke with your fingers and you poke in your PIN code. But the hand tracking at the moment has 2 big issues. For the Oculus 2 that we're using, it works less well for people with dark skin colors. It also works less well for people with a larger chest. They don't, The Meta has promised updates and improvements, but at the moment, this is the reality of what we're working with. How we mitigate it? Bright lights in the virtual outside in the room that helps to lessen the issues, and also just as a backup. We still have the controllers. They are less intuitive, but we wouldn't want people to not be able to use the environments because of these issues. Some improvements have also been made in the hardware. For example, people wearing glasses and people with visual impairments, the quality and the adjustments you can do, both with the little TV screens within the headset as with the head strap itself. You can accommodate for that, though you would need to pay extra to get the Elite head strap for that. Similar with mobility challenges, people with mobility challenges is become much more easier to just, with the trackers, they automatically reset height. So you can do it sitting instead of standing if you have issues with that. Some small improvements giving us hope. Just to summarize, I'm getting to the end of my presentation, so we have room for questions. The accessibility of software is still a big problem. Like I mentioned, in the Netherlands, there are some commercial companies offering it. There are some universities offering it, but also still either quite pricey, or you would need big tech support from within your own company. There are cheaper options available, but these are often non-interactive, non-evidence-based. Even if they sometimes say it is evidence-based, they just refer to our work as researchers, and they did not do any themselves. So to summarize, virtual reality really is a game changer in mental health, especially in anything that takes place in social environments, which is social anxieties, paranoia, and really many of the psychological issues we are facing. Especially for young people who are digital natives, it is so much more attractive to just go do and practice in a virtual social environment within the therapy setting instead of talking about it, just and having to do it at home between sessions, which is often way too scary. But we do have a problem that most of it is designed for and by white Caucasian males, and any deviation, how the further you deviate from that, the less you are represented and the less the technology might work for you. VR access is very unequally distributed. There is some access in university settings, but it's still quite horrible. Our ambitions as Orygen's VR team, it's my last slide, but we hope, and we will again, until our budget runs out, try to create as many diversity within the social environments we can think of. We are already thinking about making the environments at least as language-free as possible, the same for the controllers, that we are aiming for long-term worldwide availability. As we're a non-profit organization, we hope to do that cheaply or even maybe freely for low-income countries and provide easy training and implementation. Thank you. And are there any questions?
Thank you so much, Rose. That was a great talk, pointing out the issues that you're addressing, and very visual. Love the video. Okay, so my first question is really about virtual reality in healthcare. And so you work with youth. How well is virtual reality accepted by different age groups and cultural groups?
Yeah. I can only speak mostly from within the Netherlands, which is where I worked, and the overall acceptance, people are curious. So not only young people, they are most enthusiastic about it. We did have a great uptake and inclusion in first episode of psychosis centers, but also older people who are not used to it, they are curious. So it takes a little bit more time for them to get used to the controllers or to get used to navigating virtual environments, but yeah, it's fine. We did see on the other side that young people tended to move through it like games, so they would move really fast, get a bit of cyber sickness, which is like motion sickness. So we put a cap on that. So now they can only walk slowly to the environment.
Great. And then when you think about the uses of VR in the health field, in addition to therapy, what other types of things are people using VR for?
Yeah, at the moment, there's already a lot of research on distraction in pain. So children, for example, with third-degree burns, it's really painful. They have virtual environments available with penguins and ice, and that seems to really help during the changing of the bandages. So distraction during painful procedures, or just having fun during painful medical procedures, especially in children, is a big field. It works really well as well for relaxation because of the presence. So they done during COVID, especially with nurses in hospitals, there was often no time for actual relaxation or work break. They would have virtual headsets available to have that break, to just briefly be on a beach somewhere or swim with dolphins or get out of the stressful environment. We did see that, at least on short term, that gives a little respite in the stress levels. That's I think the most well researched. It's also skill building. So there are a lot of commercial companies as well that are now, for KLM, there's a big airplane line in the Netherlands. They would use virtual environments for training fire safety. And so you would be able to make some choices within fire safety and build those skills. So if it would happen in real life, then hopefully that is trained already.
Thank you. Mahima, what kind of questions did we see in the
wonderful.
the audience?
Sure. So Richard actually had a two-part question. Number one, he was asking if you had any reflections on VR and access issues, particularly for different types of ages and disabilities and things. And secondly, are there any medical contradictions as well?
Yep. I'll start with the medical contradictions because they are quite brief. There used to be one for epilepsy, but interestingly, it turns out that is not a problem. It is with some TVs, but the quality of the virtual headsets and the refreshment rate are much better. So we do see it's actually safe for people with epilepsy to use as well. Within the psychosis field, we do not use it when people have like a very active florid psychosis that is already hard for them to distinguish realities. And we also feel like that might not be a good time to be able to give consent to even try that. But otherwise, there are really not many or none that I can think of contraindications. So the other one was about access, but that's a quite very broad question. So maybe I was hoping maybe you could give some more specific information on that.
I have a feeling it probably was to do with accessibility, affordability, those sorts of things. Yeah.
Well, the problem is it's still not affordable for most people, even though prices are dropping very quickly. The hardware is becoming rapidly more available. So within a few years, we hope that should not be a problem. The interesting thing is that even the bad software and the clunky hardware, they gave good therapeutic results. And the thing is, especially with things like phobias and exposure, you don't need it to be perfect. People who have spider phobia, they are afraid of spiders. But even if they see a little black fluffy thing, that would already trigger that. And that would be enough to trigger that anxiety. And it's the same for VR. So even though it's not a realistic person in front of you, if it makes intense eye contact, that will trigger the anxiety. So that's the good news. But the bad news is still that, there's still a large digital divide. There's still, and there's not really one quick solution on that.
Thank you. We have time for one last question. Kim has an interesting question. She's asking if there's value for VR in some cases to do away with realistic human avatars altogether and just use non-human characters.
That's an interesting thing. Non-human characters, we have discussed that for different projects in our youth advisory groups, because it is gives sort of a mask, and they actually said they didn't want that because it felt less safe. Because you do in games, you can be, an animal or anything like that. But for the therapeutic setting, on advice of our youth advisory groups, we are for now not doing that.
All right.
Thank you, Rose. Much
Thanks.
appreciated.
I'm gonna take the host prerogative and ask another question. When you think about like crowdsourcing and citizen science, are there ways to address the inequities that you're describing in the VR world? in a more less expensive, more efficient way?
There might be. I think there's also a lack of knowledge on our side on that. We do have a very mixed team, so luckily. So we have, for example, a professional game designer who from personal interest, family interest, really feels connected to mental health space as well. So he's with our team. But he also has a lot of knowledge on more those kind of things and how to sort of easily commercialize it or make it more available in other platforms. And we are learning about that. I think it might be, yeah.